There is something about voice we assume belongs to us. The accent of our hometown. The cadence a mother used to call her children in for dinner. These feel as inherited as eye color. Now imagine going to sleep with a head injury and waking up speaking with an accent you have never used. Your family does not recognize your voice. You did not learn it. You did not choose it. I have been a surgeon for 20 years. This is the strangest voice I have heard come out of a body that should not have produced it. Let me tell you what we know. The condition is called foreign accent syndrome. It is rare. Roughly 100 well-documented cases worldwide since the first systematic report in 1947. That first report came from a Norwegian neurologist named George Herman Munrod Krohn, published in the journal Brain. The patient was a 30-year-old Norwegian seamstress who, during the German occupation of her country, had a piece of shrapnel injured the left side of her brain. She survived. When she recovered the ability to speak, her Norwegian sounded German to her neighbors. She had not learned German. She had no German connection. But in post-occupation Norway, where collaboration was the heaviest social charge a person could carry, sounding German was a sentence. She was ostracized, refused service. The injury was visible only in her speech. Munrod Krohn's analysis was careful. He proposed that what had changed was not vocabulary or grammar. The patient still spoke Norwegian, with Norwegian grammar, but what he called the melody of language, the prosody, the rise and fall of pitch, the timing of vowels, the way consonants land, the motor execution of speech. Since then, neurologists and phoneticians have cataloged cases across continents. The patient may sound French to one listener, Russian to another. The variability is not random, but it is also not a real foreign language. It is a distortion that the listener's brain pattern matches to whatever foreign accent it most recently heard. A 2011 study by Nick Miller at Newcastle University, published in the journal Aphasiology, did the largest modern phonetic characterization to date. He recorded patients labeled with foreign accent syndrome and analyzed the acoustic features. None of them were producing actual French or actual Russian. The vowels did not match those languages. The consonant timings did not match those languages. What they were producing was a motor disturbance, and the listener was filling in the gap. 3 main anatomic variants are now recognized. The first is left hemisphere lesions involving the precentral gyrus and the insula, most common, since the left hemisphere is language dominant in over 95% of right-handed people. The second is right hemisphere lesions, which tend to affect prosody and pitch more than segmental phonetics. The third is a small group of cases without any detectable lesion at all, the so-called psychogenic or functional variant. Now, to the biology. What I find compelling about foreign accent syndrome is how directly it exposes the scaffolding of voice. Most of us assume our accent is a fixed property, like our blood type, like our eye color. The clinical evidence says otherwise. Voice is motor behavior. It is rehearsed in childhood. It is maintained by a network of brain regions that orchestrate the timing of vowels, the place and manner of consonants, the prosodic contour that carries meaning beyond words. When that network is injured, the voice changes. The substrate of identity in this domain is muscle memory. The primary regions involve cluster on the left side of the brain in most people. The insula, a folded sheet of cortex tucked deep behind the temporal lobe, appears repeatedly in lesion maps. So does the precentral gyrus, where the motor commands for the tongue, lips, and larynx originate. And the connections between Broca's area in the left frontal lobe and primary motor cortex are crucial. This is the bridge that translates the intention to speak into the mechanics of speaking. In 1996, Karofsky, Sheila Blumstein, and Michael Alexander published an analysis in the journal Brain and Language of 20 foreign accent syndrome cases. They were among the first to argue that the syndrome was best understood not as one entity, but as a family of motor speech disorders sharing a common surface. Some patients had altered vowel duration. Others had altered consonant articulation. Still others had altered prosodic contour. The label foreign accent was the listener's interpretation. The neuroanatomic story underneath was specific. The right hemisphere variant deserves its own mention. Roughly 15% of cases involve right-sided lesions. These patients tend to have preserved articulation but altered intonation, flatter pitch contour, unusual stress patterns. Peter Marian at the University of Antwerp, in a 2006 paper in Clinical Neurology and Neurosurgery, argued that the should also be added to the network. Patients with cerebellar lesions producing foreign accent syndrome show that motor speech is more distributed than the classical Broca-centric model suggested. Functional imaging in recovered patients by Macquar and colleagues at Laval University in 2007 showed that recovery correlated with reactivation of paralesional cortex, the brain rebuilding the speech motor map around the damaged region. Recovery is possible. It is also incomplete in many cases. The consensus, then. Foreign accent syndrome is a motor speech disorder. The accent the listener hears is not foreign in any real linguistic sense. It is the residue of an injured motor system, interpreted by an unconscious pattern matching process in the listener's auditory cortex. Both halves of that exchange matter. This is where the case gets stranger. Because the standard story explains the patient's altered output, it does not explain why the listener hears what they hear. In 2006, Jack Riles and his colleague at the University of Central Florida published a case in the journal Clinical Linguistics and Phonetics. The patient was an American woman with a left hemisphere stroke. Different listeners, clinicians, family members, strangers, were asked to identify the accent of her post-stroke speech. The same recording. Some heard Russian, some heard Polish, some heard Czech. One listener thought she sounded Caribbean. The acoustic signal was the same. The percept was different. This is not a small finding. It tells us something about the neuroanatomy of accent perception that we underappreciate. When you hear someone speak, you are not passively decoding their phonemes. Your auditory cortex is running a high-speed match against a library of accent templates it has accumulated over a lifetime. When the input does not cleanly fit any template, your brain assigns the closest match. The patient's altered motor output and the listener's accumulated experience together produce the foreign accent. Neither alone is enough. Which means a patient in Mexico City who develops foreign accent syndrome may sound American to one neighbor and Cuban to another, depending on what each neighbor has heard most recently. The same disordered output is read differently by different brains. The accent, in a real sense, lives in both speakers. There is a stranger subgroup, cases without any identifiable lesion. In 2015, Reeves, McCormick, and Little published in Frontiers in Human Neuroscience a case of a British woman who developed what listeners called a Chinese accent during a psychotic exacerbation. No stroke on imaging, no tumor, no traumatic brain injury. The accent appeared and disappeared with the psychiatric episode. After the patient stabilized, the accent resolved. Is this functional neurological disorder, the modern term for what used to be called conversion or hysteria? Is it an undetected microlesion that fluctuates with metabolic state? Or is it a genuinely third category? A disorder of motor speech control that arises in the absence of structural injury, perhaps from disrupted neuromodulator signaling? The field does not have a settled answer. And then, the deepest case? Verhoeven and Marienne, in 2010, in the Journal of Physiology, described a Dutch speaker whose foreign accent syndrome included not only altered phonetics, but altered articulatory setting, the resting position of the tongue and jaw between speech sounds. As if the patient had been retrained, neurologically, to hold his mouth differently when not speaking. The motor disturbance reached down past speech into the basal posture of the speech apparatus. So the question I think this syndrome poses is not whether voice can be injured. It can. The question is, what voice was in the first place? If voice is sufficiently motor, if it sits on a stack of learned movements that can be stripped off by a small left hemisphere infarct, then accent is not an inheritance. It is a habit. A very thorough habit, but a habit. And like all habits, it can be undone. The Astrid case from 1947 stayed with me when I first read it. She lived for years after the war with a German-sounding voice in a Norwegian town. She did not speak German. She did not know Germany. The shrapnel had given her a mark she could not remove and could not explain, and her community read the mark wrong for the rest of her life. The active research programs working on this are concentrated in a few places. Nick Miller at Newcastle University maintains the largest case registry and continues the phonetic analysis tradition that goes back to Monrad Krohn. Sheila Blumstein at Brown University has spent decades on the neural substrate of speech perception and production. Peter Marienne in Antwerp leads the cerebellar contribution work. Jack Riles at the University of Central Florida focuses on treatment approaches. Between them, perhaps 150 new cases are entering the literature each decade. What we do not yet have is a reliable predictor of recovery. Roughly 25% of patients see their accent resolve within 3 to 6 months. Another 25% show partial improvement over a year or more. The remaining half show long-term persistence, sometimes accompanied by gradual social adaptation, but often not. The best evidence-based intervention is speech-language therapy, targeting the specific motor disturbance. Articulation drills, prosodic training, biofeedback using visual spectrograms so the patient can see, in real time, what their speech motor system is producing. But speech therapy stabilizes a habit. It does not always reverse it. And the question of whether intensive therapy ever accelerates recovery beyond the natural trajectory has not been definitively settled. There is no pharmacologic treatment with established efficacy. The psychological dimension matters more than the functional one in many cases. Patients describe being mistaken for foreigners in their own communities, marital strain when a partner reports that the spouse no longer sounds like the person they married, and a particular kind of loneliness that comes from being audibly other in one's own language. This is where the syndrome touches the same theme that I keep returning to on this channel. Consciousness is not currently a vital sign. We measure pulse, pressure, respiration, temperature. We do not measure the felt sense of belonging in one's own body. We do not measure the agreement between the voice that comes out and the body it comes from. Foreign accent syndrome is a disorder of that agreement. The body produces the wrong sound for the self that lives inside it. That is a vital sign we have not yet learned how to instrument. If we ever do build that instrument, foreign accent syndrome will be one of the first conditions it should let us see clearly. I want to come back to Astrid, the Norwegian seamstress who, after a piece of metal entered her brain, sounded German for the rest of her life. I read her case decades after she died. Monrad Crone described her with the careful attention a clinician gives to a patient he respects. He noted that she remained intelligent, kind, fully herself in every way, except for the one nobody could overlook. She spent years after the war in a community that read her injury as collaboration. Her neighbors did not understand neurology. They understood accents. And in the years after occupation, an accent could be a verdict. There are things medicine is good at. We are good at suturing. We are good at reattaching. We are good at restoring blood flow to tissues that have been deprived. We have decades of methodology for the mechanical repair of injured anatomy. We are not yet good at restoring the agreement between a voice and a self. We do not have a procedure for that. We do not have a drug. We have speech therapy that helps some patients and stabilizes others. We have psychological support that softens the social wound, but we cannot rebuild from the outside the integration that the injury broke. When I think about Astrid, I think about how much of identity sits in motor systems we never name. Walking, smiling, the cadence of laughter, the pause before a particular word. These are not decorative. They are the surface through which we are recognized. Injure that surface, and the people closest to us may never quite recognize us again. The condition is rare, roughly 100 cases. But the question it raises, what voice was before injury removed it, applies to all of us. Every voice is a habit, learned, maintained, and as fragile as the network that holds it together.